Good afternoon, everyone. My name is Terry Phillips, and I'm the facilitator for the Heroin Task Force. It has been my pleasure to partner with the Waukesha County Health and Human Services and all our community partners on this very, very important work. So I am going to screen share real quickly here so we can, whoops. All right, you guys can see my screen okay? All right,
Yes.
fantastic. So welcome to our first quarterly meeting for 2023. And as you now have entered this virtual room, just everybody take a deep breath. Know you've had a busy day, and we are grateful that you are spending this time with us today. So take a deep breath, get yourself centered. You've committed the time to be with us, so be ready for some really interesting and informative information that we'll be providing you. I'm going to turn it over to one of our co-chairs, Larry Nelson, to welcome everybody.
Thank you, Terry. And it is my honor and pleasure to welcome all of you. It looks like we're up to 49 people, and hopefully a few more people will join, but we really appreciate you taking the time to be with us today. We have a lot of good information and a great speaker. But first, it's also my honor to introduce our county executive, Paul Farrow, who has been a leader in Wisconsin and the country in helping us trying to address the heroin, opioid, and sadly now the fentanyl issues facing our county and state. So I'd like to ask Paul to say a few words to the group. Go ahead, Paul.
Well, thank you, Supervisor Nelson. Larry is a good friend, and boy, I'm seeing a lot of great friendly faces on the screen. It's been way too long since I've been with this group, but I just want to say thank you for all the hard work that you're putting in. As you all know, last year, I created a community health crisis regarding fentanyl. I was just on a call just a little while ago with my team, working on some new phases of that and what we're trying to get accomplished. But I will tell you, for me, it's been exciting. I think it was the last 3 weeks now, I've been out talking to individuals within the community, and the response that I'm getting isn't oh, that's something new, or we really shouldn't talk about that. How do we get involved to help you get the message out there? And this is actually coming from businesses, the schools, communities. The level of engagement has just gone through the roof. And I think it's partly because of the work that we've been doing across the board, but mostly the work that all of you have been doing, getting that message out, getting people to realize that whatever the situation is somebody's dealing with, there are people here that can help them. In the different groups, the different organizations, the different entities, we're here to help. And that's what we're going to continue to drive forward as we go through the next couple of years, trying to reduce the impact of these terrible drugs that have in our communities. I can't tell you enough how grateful I am that we've got partnerships like this, and the reorganization that the task force has gone through post-COVID is exciting to see. And I appreciate Larry's leadership in this program, and Terry, your involvement. It's so good to see you again. I miss the conversations, even when we went back and talked about education.
We did a lot of that.
But as you all know, my goal is to rally the troops as much as possible and get people together to say, how do we impact this together? How do we bring our resources and then amplify them? And I am excited to say that I think the press conference we were just talking about in May, we're going to introduce, and I'm going to give a little bit, Nicole, you can kind of fill in too, but we are in the process of purchasing 100 of the oak boxes that you may heard, the overdose action kits that are out there. My goal is to get these to the municipalities, to the schools, to businesses, to anyone in Waukesha County and the communities that we can set them up with and we can help out. And if I have to, I'm ready to order more as quickly as possible. I want people to realize that we have opportunities in front of us to not only save a life, but change a life. If someone overdoses and we can get the naloxone to them quickly enough, give them a second chance, and then give them the resources they need to really have a super second chance to be successful. And so whatever I can do, I'm going to continue to push forward on that as we work through some of the other fun challenges that we have in the county. This is one that I know that the community effort that I'm seeing right now is really starting to amplify, and we're excited about it. So I wish I could stay for the whole meeting. I'm going to be jumping off in just a little bit. I've got another event to go to, but I want to just give a quick opportunity to say thank you for all the hard work that you're putting in, and know that you got a partner and a team in Waukesha County that's ready to help out wherever we can. So
Paul,
Larry, I'll turn it back to you.
thank you.
Well, Paul, go ahead, Terry.
I was going to say, I just want to make to clarify, these are the overdose aid kits that you're talking about. Okay, I'm going to pop that into the chat for everybody, and then Larry, you can continue.
I was just going to say thank you, Paul. We appreciate so much your leadership and your support of this group. I've gone to some presentations at the National Association of Counties, and we are really doing our slogan, we are leading the way because we have so many people involved in this task force. And so thank you very much. I also want to give a shout out. We have a record number of county supervisors attending today. So I want to recognize supervisors Christine Howard, Matt Wheel, Johnny Corminos, Gary Sapara, and Sarah Fraley, our excellent legislative policy advisor. And so glad to see those people with us today. And at this point, Terry, I think we're ready to go to you for our goals, agenda overview, and virtual meeting guidelines.
You got it. I'm going to share my screen again here. And we'll take you through goals and objectives really quickly here. Our goal is for us to have an opportunity to network. And that's why when some of you got here early, we gave you an opportunity to start chatting with some of your community partners. We are going to be highlighting a partner agency at each of these meetings. We're making a few changes based on the survey at the end of last year. So that was one of them. We want to hear from our partner agencies. Today is Elevate. They're going to model what this looks like. And if you are interested in being highlighted at one of our future meetings, let me know or let our administrative assistant Shannon know, and we will get you on the calendar. We're also going to have an opportunity to do a few partner updates. So right after our little short break, we're going to have announcements, if you will. So if there's something that you want to share with the rest of the community partners, or something you want to push out, that is your time. We're going to spend some time working on our action teams for 2023. We are just beginning to launch them, so you haven't missed anything. We are right at the precipice of launch, so we are just starting. And then, of course, our featured guest speaker, Dr. Nicole Matson from Marquette, is here. And I will tell you, her presentation is excellent. I've met with her quite a few times in preparation, and I'm excited for what she has to share today. So real quickly, a couple of meetings ago, I realized not everyone's using Zoom anymore, and I wanted to make sure everyone knew how to navigate around Zoom. I know some of you are on computers and phones and iPads and what have you, but we are going to ask you, and I think everyone kind of has gotten used to this, to stay on mute when you're not speaking, just to avoid some of that background noise. But we would love to see your face if your internet connection allows. So I see a lot of you have done that, so I appreciate that. The chat, I encourage you to use the chat, and you have several of you are already doing that. There were some great thanks to Paul for being here and our other elected officials. So we'll use the chat to be asking questions. The other feature I want to draw your attention to is the reaction button. There is a hand raise feature there, so please feel free to raise your hand. Raise your hand on the computer because it pops you to the top of our screen. My tech producer, Rachel Moore Baird, is with us today. Thanks, Rachel, hailing from Nashville, Tennessee. And she and I will keep an eye out in the chat, as well as your hand being raised would really be helpful. So that is just a quick little overview of some things I want to draw your attention to. And then each time we get together, we've talked about this, use the hand raise feature, mute your mic when you're not on. be fully present when you're here. I mentioned that at the very beginning. Set things aside so you can really focus. There's a lot of really good information we're going to share with you. Be mindful of airtime. There's a lot of us here today. And then when you're done speaking, say, I'm complete, I'm good, that's it. So the next person is ready to go. All right, so we are now, you've got the agenda, so I'm not even going to step through the agenda. You all have that. We're now going to do an agency spotlight. And Rachel, it's Mary Simon who from Elevate, who's going to be our agency spotlight. And I am going to stop sharing so y'all can see Mary, and we're going to get her spotlighted. Great. All right, Mary, turning it over to you.
All righty, thanks, Terry. I appreciate it. And I want to echo Larry's welcome. I serve as the co-chair along with Larry for the Heroin Task Force, and I'm just so excited to see you all here, and I'm excited to hear the speaker as well. So I'm the guinea pig as far as the first agency spotlight. So I'm hope I get it right, but I'm going to go forward and see where we go. Elevate, for those of you who may not be familiar with us, we are a private nonprofit agency. We were actually formed in 2014 as a result of a merger between two nonprofit agencies, one focused on substance abuse and one focused more on mental health services. Our mission is to guide and empower individuals, families, and communities to effectively address substance use and mental health challenges. And we use, we have a lot of different strategies that we use to try to achieve that mission. First strategy is really focused on the prevention side of things, working with youth and the communities and the schools that they're in to help delay their use of alcohol and drugs for as long as we possibly can, because we know that the younger they start, the more likely they are to become dependent later on. So our goal with our youth prevention services is really to help youth delay their use. For some youth, that means from 12 to 14. For some, it's 14 to 17. For some, it's 17 to 21. So really the goal is just to delay it. Our second strategy is focused on intervention services. So that's really working more with individuals who have developed a substance use disorder or a mental health issue. A lot of the clients that we work with in that program area are involved with the criminal justice system. So we're working to divert them out of the criminal justice system into treatment, into recovery. And then the third strategy that we use is our supportive services. So for those individuals who have a substance use disorder or a mental illness, how can we support them and help them to maintain their recovery and live a good, solid, positive life? So those are kind of some of the strategies. Our home base originally is Washington County. In 2016, we ventured into providing services in Waukesha County through the Drug-Free Communities grant, which is a federal grant that was focused on youth prevention. So we had worked with a coalition in Waukesha County, really focusing on youth prevention. That grant ended, and we were able to secure some additional funding through the state of Wisconsin and through Waukesha County Health and Human Services to keep providing prevention services in Waukesha County. So I just wanted to highlight some of those that we're doing. The first strategy we use is really focused on middle school youth. And we implement a research-based program called Too Good for Drugs. We do it at all three of the city of Waukesha public schools. So we're at Les Paul, Butler, and Horning. It's a 10-week program. So we go in typically once a week and teach a lesson to all. At Les Paul and Butler, we're in 6th, 7th, and 8th grade. And at Horning, we're in 6th and 7th grade. So we go in and we teach this 10-week curriculum to the middle school students. Just to kind of give you a sense of the size of that, that's about 72 classes of middle school kids. So God bless the staff that want to work with middle school kids, right? But it's a great program. It's really educational based and teaching life skills, and it's an evidence-based program that has been proven to be effective. So we're thrilled to have that opportunity to go into the middle schools in the city of Waukesha and teach their kids. The second strategy that we have is focused on high school youth. So we implement a program called Peers for Peers. It's a peer listening, peer leadership program where we train high school students to be peer leaders for their friends and their classmates inside the school. Because they don't like to talk to old people like me. They like to talk to people their age. And it's a great resource for them if they're struggling with something that's going on at home or a school or a boyfriend, girlfriend issue, that they can reach out to those peers and find someone to listen to them and guide them and provide them with resources if they need it. We're thrilled that we are in all three of the public high schools for Waukesha. So we're at North, at South, and at West, but we're also in Arrowhead and Pewaukee and Menominee Falls. And we just started a new program this year in Muskego. So all of those students are trained. We bring them together 3 times a year. All Waukesha students come together 3 times a year for training. We just had our spring training. The Love Logan Foundation came in, so we heard them at the press conference, and Aaron and Rick Rockwell came in and told their story. It was a huge success for the kids to hear from a mom and dad who had lost a son. And so it was a very powerful presentation, and we were thrilled that they could come in and help us train those high school students. And then the last strategy that we are implementing in Waukesha County is something called the Elevate Communities Project. For those of you who are familiar with prevention, you know that this is a huge problem. We can't do it all by ourselves. And so working in coalitions, working with groups of people to try to address those issues, we have much better success. So we have a coalition centered at the City of Waukesha school districts and one in the Menominee Falls School District, where we're bringing school stakeholders together and community stakeholders that may impact on the schools to really look at the data on what's happening with their kids in their schools, and then identifying goals and objectives that they want to work on within their schools. Just to highlight really quick on what they did, one of the activities that these groups just did was something called Be the Majority. It was at the local or was at the basketball games recently. We went to 2 basketball games, and the purpose of it is it's a social norms campaign. So many times people think that kids think that every kid uses, right? Everybody drinks, everybody's smoking on the weekends. The data doesn't show that. And so the Be the Majority campaign is really trying to highlight that, what the actual data is of how many kids are reporting use, and letting kids know that they don't have to use, and that there's a lot of kids out there that aren't. So we really like taking that more positive approach instead of saying, things are bad. They're not bad, right? You might have a perception that they're bad, but there's a lot of good things that are happening. And then how am I doing on time, Terry? Am I okay? All right. So one more thing that I just wanted to highlight that we're really excited about is we have as most people know, that youth are opioids and heroin aren't necessarily the place that kids start with their drug use. We've seen a dramatic increase in vaping among the youth. And so we have created an Escape the Vape room where we have a chance to educate kids about vaping using that very creative strategy of an escape room. So our peers, our high school students, are trained to go out and to offer that opportunity for like the middle school kids to enter in the Escape the Vape room, learn a little bit more about vaping in a fun and interactive way. So that's Elevate in a nutshell. I am going to put our website in the chat so that if you would like to learn more about what we're doing and get involved, if you are a parent at Menominee Falls or at Waukesha School District and you want to get involved, with our Elevate Communities project or any other way, feel free to reach out, and we'd love to have more people at our table. So any specific questions for me at all?
Larry.
Well, first of all, I want to publicly thank Mary for being a terrific co-chair. She and her organization, Elevate, came to the rescue of our Waukesha County Drug-Free Communities Coalition when we needed a fiscal agent, and it's so great to see some of you who were involved with that. I did want to share that CNN recently had a national town hall on the fentanyl crisis, and Mrs. Logan and her surviving son were on there, and they did a great job, but they both talked about how they really were unaware of fentanyl until sadly it killed her son and his brother. And I thought it was really good that they had the brother, because you often don't think about how does that affect a sibling, as well of course, the trauma for parents. So that's great that you had them get into the middle schools, because as a former middle school teacher, that's, I think, the age where you need to reach them before they get totally off track, which often happens. So thank you, Mary.
Thanks, Mary. And I did pop in Shannon's email. If you would like to be our agency spotlight for June, just let us know, or September or December. So please let us know. I'm going to turn it over to John Kettler. John is going to share some information, and I did send some of this out in the email to y'all. John, I can share whatever you would like me to share. If you want to start with the updated statistics on Waukesha County drug-related deaths, is that a good place to start?
Sounds good. Thank you, Terry. Yeah, if we want to share the death statistics, I guess that's a place to start. So that would be great. Thanks everyone for being here. Happy Pi Day to everybody who celebrates math. My name is John Kettler. I work with Waukesha County's Department of Health and Human Services, and I'm grateful to be here. Want to share a few things, take 10 minutes, maybe a little less, to talk about our changing drug landscape, which is sort of a theme for our group moving into 2023. And we'll start, unfortunately, with these drug-related death statistics. So let me start out by saying that what you see there for 2022 is to date. So that is not finalized. The state crime lab, the hygiene lab, is a little behind on processing samples and things. So often these statistics are not finalized until later in the year. We had Chris Clens from the medical examiner's office about 6 months ago join us and share a little bit. So this is a bit of an update to that. And I just want to call out a few things. Terry has shared those with you previously, but I just wanted to share that everybody's work here through the task force, through all of the efforts in the community, the whole collective impact, doing great work, got us in 2019 to a low point for looks like 6 years, to get us down, and everybody's work, and what we're doing matters, and it helps, and it has an effect. So please keep doing what we're doing. Now, unfortunately, fentanyl came along, and so we're seeing a couple of really large jumps in the last 2 years. I'll share that from 2019 to 2021, in a 2-year period, we jumped from 54 drug-related deaths to 105 drug-related deaths. That is a really, really big jump. And all the modeling shows the huge increase in fentanyl has led to the huge increase in overdoses. A little bit about this here, a question that I know will come up is the homicide category there. That is, I double checked with the medical examiner's office, and that is related to someone injecting another person with the drugs, helping them to use the drugs, and that was considered a homicide. So that is what that total is. We can see that there are consistently more males than females overdosing. As such, there's some efforts to target our online efforts and such accordingly when we're able to specifically target. but obviously to the whole county, and then here's kind of the big takeaway for me. If we look at the heroin on the lower graph, total heroin related deaths actually went down from 2019 to 2021. The number of heroin related deaths went down, but at the same time, over to the right, the number of fentanyl related deaths jumped from 25 to 72. It almost tripled. So we're seeing that fentanyl is the huge driver. And I would add an opinion that I think that the heroin we have is not heroin. And so what folks are using is not what they think it is. So I do encourage everyone to, to share that information, to embrace fentanyl test strips, and try to, taper what our activities for this next cycle that we're kicking off around the data. So Terry, I suppose you could take that down. I want to move into talking about xylazine next, if that's all right. Try to keep us on track here time-wise. But before I talk about xylazine, I want to talk about nitazines. We've heard a lot about fentanyl and fentanyl analogs over the last few years, and nitazine is a comparable thing. It's not fentanyl, but it is similar, and it is 20 times stronger than fentanyl is. So this is being seen. There's almost 1,000% increase nationwide in seeing this. Appearing often with fentanyl or around it. So this is unfortunate. This is another name we're going to hear, particularly isotonitazine, which is one of those words that your Word documents will probably underline in red until you add it to your dictionary. Isotonitazine is one of the primary ones. It's called ISO for short, and it's essentially another like fentanyl that is being seen, and we're seeing a sharp increase in deaths and a sharp increase in the prevalence in the United States. So that's one for us to watch. And I wanted to talk about xylazine, which is a tranquilizer. We'll get some information on this in the chat box. And I know Terry has shared a few articles in advance. So again, xylazine is a tranquilizer. It's often found with fentanyl. When fentanyl is found in drugs, it is often found alongside it now. And it is in at least 39 states, including Wisconsin. This tranquilizer is really strong. This can knock out someone, not just for hours, but even for days. So the presence of this is very concerning. It does not respond to Narcan. Unlike the opiates, this is not an opiate. So administering naloxone or Narcan is not going to reduce this portion of the overdose. We should continue using, please hear me, you should continue using naloxone and Narcan, same thing, in overdose situations, because the protocol really hasn't changed. However, there's a lot of concern about xylazine. It doesn't respond to Narcan, so if that is on board, it is possible, in my estimation, that this may confound our EMS a little bit, because normally folks come back with the naloxone pretty quickly, but if somebody's knocked out on xylazine, they could be unconscious still for hours, even though it's not an opiate. This would cause the EMS to use more naloxone than was necessary, deplete the naloxone supplies, be kind of confounded by that. So,
hey, John, can I stop you for just a second? Elizabeth has her hand raised.
Sure. Elizabeth?
Yes, I'm Elizabeth Phelps. I'm a house manager at Samad Sober Living House in Milwaukee County. We have had a couple of run-ins with both isotonitazine and with xylazine. Xylazine is known as the zombie drug because it actually eats your flesh away. There is no known counter-reactant for this particular drug, but I do know isotonitazine, the Narcan, does work, just not as effectively as it would with fentanyl or heroin. We have seen quite a bit of statistics. It's hit Pennsylvania, it's hit Wisconsin, it's hit Milwaukee County. So we are definitely, that is one of our big campaigns that we are going to start launching, get more information on there and figure out exactly how we can combat this particular one, because this one is a doozy.
Yeah. Elizabeth, thank you. Thank you for sharing that.
Yeah, thank you. And I know of at least one manufacturer who is rushing to manufacture xylazine test strips, which would be helpful in this case. Xylazine is a bad drug. Aside from being a tranquilizer, if someone injects it, it can form necrotic patches, meaning that the flesh right there dies, and it can actually die not just at the injection site, but on downstream with the drug as well. So there are some pretty graphic images of people who've had to have amputations from this being in their drug. So I'll drop a few more links in just a moment into the chat about xylazine. And I just want everyone to know that we are going to begin testing our substance use patients in the Health and Human Services outpatient clinic. When we do drug testing, we're going to start testing for xylazine and gather some data on that, try to help us get a handle on the prevalence. We know that it is around, so try to see just what the prevalence is, and I'd be happy to bring that data back, maybe in 3 months to our next meeting.
Great. Thanks, John.
Great. And I'll move on. There was another topic we were going to cover just in the kind of a bit of the response, and that is around the toolkit that Waukesha County has put together and shared. And I know that Terry has shared that previously with this group. Be great if, yep, right on cue. Thank you, Terry. Wonderful partnership. Appreciate you. So just, quick shout out to the county exec, the HHS directors, the PIOs, and all involved with putting together this toolkit. It is meant for folks to use to help message out around the fake pills, around fentanyl. It has facts, it has sample messages, it has images. A lot of this kind of comes from like the One Pill Can Kill campaign from the DEA, as well as the Fentanyl is the New F Word campaign from Saving Others for Archie and Love Logan. So we want to get that out. It is okay to use those images. It is okay to amend those images. If you want to co-brand, put your agency's tag on out there and get some posters out there, feel free to use the images. We sent out an initial version, and then about 6 weeks ago, an updated version that has kind of youth adolescent images as well, which we're getting out there now. And so we've used these and encourage others to use this messaging. Right now we have it on social media, on buses, on bus shelters. We're doing targeted online advertising. And just about 2 weeks ago, we got posters with these out to every middle and high school. So our school partners and those working with school partners, please encourage them to try to get those posters up to create awareness of fentanyl and the fact that there are fake pills out there with the adolescents. So that said, I'm going to go ahead and stop there to respect our time. But if you have any comments or questions, feel free to drop those in the chat box or to email me, and I'd be happy to follow up.
Thank you, John. One of our participants just said that the resource page that I just popped in was not working. So let me check that while Kirk's talking to make sure I've got the right link. I thought I did, but maybe I missed a little end to it or something. So I'll get that back in there.
Wonderful, thank you.
Thank you, John. So back in September when we did some action planning, as John mentioned, what really stood out was the fact that the drug landscape continues to change. And we have to be flexible and be able to pivot. And that is why these action teams are pivoting again this year a little bit to be more responsive. So we're going to turn it over to Kirk Yockler, who's going to share a little bit about where these action teams are going. We are, again, just at the beginning. We have some wonderful leaders that have stepped forward, but you haven't missed anything. If you want to participate, if you said, yes, I want to participate, you haven't missed anything yet. So Kirk, I'm going to turn it to you, and I'm going to go check out these sites while you're talking.
Okay, sounds good. Thank you, Terry. Hello, everyone. Thanks for being here today. Yeah, I mean, John's description of the new drugs we're seeing, what a graphic illustration of that changing drug landscape that Terry just referenced. And again, on our in our key themes that emerged from September 14th community gathering was that this changing drug landscape continues to evolve, and it's critical that we have action teams that can remain flexible and pivot to respond to these shifts. So I'm going to talk about the 4 proposed heroin task force action teams, or they're no longer proposed, the action teams that have formed for 2023. But I think you'll agree that they really respond to that need for flexibility. And Terry, were you going to be pulling up the slides on the?
Yep. And I
Action.
forgot I was screen sharing. Isn't
Okay.
that lovely? Sorry about
You're
that,
checking
everybody.
stuff
I
out.
was,
That's
I
all
was
right. You know,
trying to find the right
we'll be
link,
flexible.
and I forgot that I was screen sharing. All right, here we
Yeah,
go.
and I
How's
think
that?
Terry was going to share, or will share, the link in the chat, the overview of the 2023 action teams. That'll give you a little bit more information. But
So are you seeing it, Kirk? Or
I did see it come into the chat now, and I do see the slides. So
perfect.
the stigma reduction action team, again, looking at reducing stigma and building understanding of substance use disorder and harm reduction strategies, and creating a shared common message. And then support recovery reduction action team, providing recovery support for individuals and families. Just want to check. Is the reduction an addition there?
No, I
that
think
was
that's
a
my
mistake.
mistake.
Okay,
Yep, it sure
yeah, there
is.
we go. So it is actually the support recovery action team.
Action team.
Reduce it by the one word.
Sure will. Oops.
All right, good. And, again, that's supporting recovery through peer support, communicating available resources, increasing treatment interventions. One of the examples that we gave in the formation of these was the MAT in the jail initiative that actually came out of the Heroin Task Force. Medication-assisted treatment in the jail, supporting families and loved ones families who have lost a loved one or who are in crisis. The third one, the CHIP Substance Use Action Team, CHIP stands for the Community Health Improvement Plan. That's a 5-year cycle that's led by the county's public health department, but it includes a ton of input and participation from the community. And in a prior CHIP cycle, the entire Heroin Task Force took on one of the action team roles. In this one, the CHIP community health assessment identified substance use as a key area to focus on, and it's actually going to be this action team within the Heroin Task Force that's going to take that on in partnership with CHIP. So identifying opportunities to improve policies in upstream work and to support system level changes is part of that. Can include educating policymakers, influencing stakeholders, addressing workforce challenges of substance use disorder professionals as capacity for services increase. So a lot of work that can be done within that action team, and we appreciate the connection to the CHIP initiative. And the metrics and measurements action team, this was one of the action teams from our last cohort. Initially, we had modeled this action team as sort of a support action team for all of the other action teams, and realized that there was a lot of good work that they were doing themselves that led to a decision to have this action team carry forward into this cycle as its own action team. Can continue to provide support to the other action teams, but will identify its own initiatives and things that it wants to accomplish within that time frame. So I think that's a pretty good description of the action teams. The other thing I would say is we have fabulous leaders stepping forward for the action teams, and please thank our team leads. Their information is going to be on these slides here. And I should note that these action teams are just beginning to launch. So we just got through the work of confirming all the leaders. There's still time to get involved. One of the things, Mary said it well in her agency spotlight, this is a huge problem and we can't do it by ourselves. So again, these action teams are really aligned with an opportunity for the entire community and stakeholders to come together around this. The other thing I would note is that we definitely want to give these action teams at least a full year. So we're not going to be restricted by the end of the calendar year here in December 31st. There's no deadline. We're really looking at, similar to the last cohort of action teams, about 12 to 18 months to accomplish the initiatives that they set forth, or form some recommendations if they can't get a particular initiative to the finish line within that time frame. So there's still an opportunity to sign up for an action team as a member. Again, if you want more information, that link in the chat will tell you a little bit more about each of those action teams. We're going to do a little brainstorming today in breakout rooms, and you can give your email to the chairs, or you can always send our wonderful administrator an email. So we'll pop her name into the chat. Shannon Gustafson will be your contact. And so she'll get your contact information to the right action team chairs. And we're really excited that you're here and ready to provide some input and ideas to share with these action teams.
So Kirk and Terry, my understanding also, when we send the recap for this meeting, there will be a link where people can sign up there. Terry, is that correct?
Actually, we're just going to go right through Shannon, or if people go into the breakout rooms, they're going to be with the chairs. They can absolutely
right. But let's
chairs,
say people wait to see how the rest of this meeting goes. We'll be providing Shannon's email in the recap. And so it's easy to sign up. I believe all these committees meet virtually for just about once a month for an hour or so. So one of our hopes is that all of you that have the time, and hopefully it's a win-win with your day jobs, to get involved in one of these action teams. Thank you for that clarification.
Perfect. Thank you. And Kirk, thank you for providing the overview. This is really exciting. The action teams that are in front of you today came out of our action planning in September. So this came through you as community partners. And you'll also notice that each one of these are things, as Kirk said and Mary said, we can't do by ourselves. We can't reduce stigma by ourselves. We can't support recovery by ourselves. It is true collective action that will make this happen. So at this point, we've kind of fire hosed you all with like a lot of information in about 40 minutes, 35 minutes. So just take a breath. And I think I need to too, since I was like sharing my screen with you and forgetting I was sharing my screen with you. So we are now going to put you guys to work, and I'm going to walk you through the exercise, and just be patient with us. And this time I am going to screen share, I think, the right screen. So give me one moment and we'll walk you through our exercise. So as Kirk mentioned, these teams are just starting, the team leaders are just starting to meet one another. And we felt that today would be a great opportunity for us to gather some information and some ideas from our partners so they can at least have some things to start with. So we are going to go into some small groups to brainstorm. And we'll think of it as a little competition, like which team can generate the most ideas. We're going to have you self-select into breakout rooms, and I'll tell you what that means in just one second. Normally, you're sucked into a breakout room. We wanted you to have the opportunity to choose which breakout room you would like to go to. Support recovery, stigma reduction, the CHIP, or metrics and measurements. You can choose, and we'll tell you how to do that in just a second. One of the team chairs is going to screen share so you can see the directions. And we're going to ask you to take a couple of minutes to individually brainstorm, how might we reduce stigma? How might we support recovery. So we've got some questions teed up that we're going to ask you to do some individual brainstorming. And then we really want you to generate as many ideas as possible. This is not the time to say, oh, Terry, we don't have money for that idea. Terry, that isn't a really good idea. For whatever reason, we want all the ideas to just be captured. And then we want to be able to gift that to the action teams so they can start going through them and deciding what makes sense for them to work on over the next 12 months or so. We're going to give you about 15 minutes to do that. And then at the end, just ask you to highlight a couple of themes. So now we also know that many of you are here to hear our speaker and might be new to the Heroin Task Force, or just might be new to the Heroin Task Force. We're going to invite some of you to stay back into the main room, not to self-select, if you want to learn more about the Heroin Task Force. So Mary Simon from Elevate and Larry Nelson, our two co-chairs, they're going to hang back, and you can ask questions of them. They can give you a little history of the Heroin Task Force, some of the things that have been accomplished over the many years. So if you want to hang back, don't select, okay? And this is how this works. So if you join a breakout room in Zoom, or we're asking you to self-select into a breakout room, once Rachel opens the breakout room, at the bottom of your screen, you're going to see this cool little breakout room icon. You will then be able to join, and they are named. You will be able to join and click yes, and it will take you into the breakout room. Those of you who are in this going to support recovery, I think it's support recovery is where I'm going. Yes, support recovery, just sit tight because I am going to come and help James and Susie with that one. Joy from Elevate, you said you don't have the slide deck, but I think Colleen does. Oh, Joy, you don't? I will make sure you have access to the slide deck. So that I thought I gave it to you, but we'll make sure you have access to the slide deck. If you can't do this, you're on a phone or I can't figure it out, sit tight. Rachel, our wonderful tech support, is going to help you get into your breakout room. So these slides, for those of you who are in the breakout rooms, look like this, and they will introduce the question to you and give you some time, and all the directions are there. So I'm going to stop screen sharing for just a moment here and pause and see if you have questions. And I'm going to give Joy Evans, right? You need, there we go. You got it? Okay, perfect.
Terry, I have a question. How
Yes.
long will this small group breakout last? When
Great
is our
question.
break and when is our speaker?
Perfect. So it is 3:20 now. We're going to give you 15 minutes in the breakout room. So we'll be coming out at 3:40. Do quick report outs. So from 3:40 to 3:45 is our break. And then our speaker will begin promptly at 3:45. Thanks, Larry. Any other questions? All right, we are going to make this happen. Thank you, Rachel, for helping us out. And there you go.
Terry, are you back to take us into our break?
I am back. I wanted each team just to spend like 1 minute kind of sharing how your conversation went. So how do those breakout rooms go so fast? I mean, it just is, right? Okay, so stigma reduction action team, I'm going to screen share. So you guys, if you can just share a little bit, like 1 minute of you know, kind of the theme that you were hearing during that conversation, or how it felt even.
I can go. We ran out of time. We didn't even get to highlight or choose a reporter, so I'm just stepping in. But the one main thing that seemed to be overarching was language and being careful of our words and how we use words when we talk about things, because that increases stigma instead of reducing it. Trying to change how people view the condition more as a medical condition, just as they would diabetes or something else, and not as a personal deficit somebody has. And then the stories and the events where we can reach out to people, because stories mean a lot. And and what Christina had talked about before last week when we were talking about not waiting for someone to reach out, but being ready and being proactive and reaching in to help people, because otherwise they're not going to reach out.
Yep. Fantastic. Interesting.
So Terry, can I interrupt?
Yeah.
Colleen, I think if your committee could come up with a glossary of terms and the best language to use for a lot of these issues, as a former middle school English teacher, I think that would be fantastic to put something together, because one of the things that I've learned over the years, some of the acronyms and labels that we used to use are no longer accurate or the best use. But I think that's something, if your action team could attack, I think that would be great.
There's something out there right now that I actually just printed out to have. So there's already things done.
Okay.
But what I'd like to do is take it and share it with agencies so that they can look at their literature and make sure that they are matching what it should be.
Exactly.
And we all can learn. I mean, we all, yeah. So anyway,
And
that's a good
great.
idea. Thanks, Larry.
And that came up in ours as well. Jim, can you unmute and kind of share quickly kind of what our theme was? We heard language too. Jim, if you want to unmute.
Sure. I think the one of the themes that came out was just being more present in the community, being accessible, visible, so that people don't have to seek us out. I think, as someone else put it, that's a great point.
Yep. And knocking down some barriers. We had actually a couple of pages. We did talk about the change in the vocabulary as well. So, and again, this is something where our coordination with those two teams is going to be really important. How about our CHIP substance use action team, Haley, Sarah?
Hi, I will report off. We also ran out of time very quickly, but I will mention two things that we talked about. One, education advocacy, making sure, certainly a lot of that work is already happening with stigma reduction in the agencies who are working with our schools, but that did come up as a theme or an area. Also housing, but the overarching theme that I think points to both of them is our policies do not always support where people are at their point in recovery. That's whether somebody is on medication assisted treatment, it may prevent being eligible for a housing voucher, or being dual Medicaid, Medicare, that might prevent being able to obtain certain services as well. So I definitely think that was a theme that came out of that very brief chat that we had together.
Yeah, it sure went quick. It sure went quick. And then our final team, but last but not least, our metrics and measurements team, Francis and Felicia.
Yeah, so metrics and measurements really had twofold of themes that emerged. The first one is connecting with the right entities to get the right information. So whether that's getting the medical examiner data, like John shared at the beginning of our meeting, really delving deeper into that, or connecting with the county's fentanyl task squad. And then the other side of that is making data really accessible and improving data literacy. So whether it's improving visualization to improve knowledge, or teaching people how to read a data report, whether it's this group here or it's the community, so that we can really show the efforts that we are making in the community, both now and over time, and how they really help our community. And we can show and tell that story through data.
Fantastic, Francis. Thank you. Folks, that was outstanding. I know it was short, but it certainly gave a little jump start for our action teams. We are going to give you 5 minutes. So it's 3:42. So at 3:47, if you want to turn off your video, just turn it back on so we know you're here. We will start right at 3:47.
Perfect. Well, thank you, Terry, and thank you, Colleen, for that wonderful introduction. So because the recording stopped for a second, I'll just reintroduce myself quick. I'm Nicole Matson. I am an assistant professor for Marquette University within the College of Nursing. And I'm thrilled to be here today in this community, because this community is doing such great work to help really advance and understand the way that opioids are impacting our community here in Waukesha County. So as Colleen had mentioned, I've worked with women and children my entire nursing career. And so this is an area that I'm passionate about. And I'm hoping to talk a little bit today about, well, my plan to talk today is about my research findings that I had in a study that I conducted just recently, where it was examining the ways in which women who have chosen to use medications for opioid use disorder for their recovery during pregnancy and that early parenting period, so that first year after having given birth, and how they're making that transition to a new parent while also managing their recovery process. So I just wanted to, let me forward my slides here. No conflicts of interest to disclose. And really, I'm hoping today that you can walk away with a little bit of an understanding of how the harm reduction principles have been embedded within perinatal opioid use disorder treatment care that we provide. And then also this ability to discuss ways in which mothers using medications for opioid use disorder are engaging in self-management in that first year of recovery after having a baby. So I wanted to start with a story. Through my research, I've had the opportunity to interview mothers who self-identify as being in recovery. And I've been able to interview them regarding their recovery journey as well as their transition to motherhood. And one mother who I'm going to call Janelle for the purposes of our presentation today, shared with me 2 of her birth experiences. So while her births were 12 months apart, they were vastly different experiences. And so I'm going to use them to highlight some of the things that we see as challenges and opportunities for this population. So Janelle was using opioids when she found out she was pregnant. And she was about 2.5 months pregnant when she found out. And the moment she found out she was pregnant, she knew she needed to do something to get herself healthy because she wanted to do what was best for her and her baby. She went and found a doctor that would prescribe medications for opioid use disorder and began their program. She started working that program and took a lot of pride in the fact that she had only one time where her urine screen came back with the presence of drugs, and that was during her very first visit. So she worked the program, attended all of the different counseling, group therapy meetings, and all the scheduled appointments. When she was progressing in her pregnancy and getting to the point where she was ready to deliver, when she went into labor, the hospital that she had planned to deliver at was actually 45 minutes away. And when she went into labor, she didn't feel that she had enough time to drive all the way to that hospital. And so she went to a local or the closest hospital near her home. When she arrived, she was upfront about her substance use history and her current recovery work. And at that time, when she arrived at the hospital, she was already fairly far advanced in her labor progress. So she was 6 centimeters dilated and was already looking to have an epidural. She was told by the provider that was caring for her at that time that she could not have an epidural. And so she continued to labor and over time asked again for an epidural to see if she could have something for pain and was repeatedly told no, she could not get an epidural. She labored for 5 hours after getting to the hospital and pushed for 2 hours, all without receiving any pain medication. While she was laboring, she also missed her scheduled dose of her medications for her opioid use disorder. And when asked the provider if she could get a prescription for that and take that while she was laboring, the provider stated, "You've been getting your baby high enough. I'm not bringing him into the world high." After the birth of her son, she experienced some long periods of time where the child was separated from her. So the baby was taken to the nursery or the nurses were watching over the baby. And she stated that that was one of the most traumatic pieces of her birthing experiences, hearing her baby cry when the baby was outside of her room. She also mentioned to me that one of the biggest things that she had known that you don't want to do for a baby that potentially is going to have some withdrawal symptoms is separate mom and baby. Eventually, over the course of her stay in the hospital, she ended up calling her doctor that she worked closely with at her recovery and treatment clinic. And that provider phoned in her medications. Her significant other ended up picking up those medications and bringing them to the hospital for her. After 5 days, when she was discharged and went home with her baby, she felt very hurt and frustrated and angry about her birthing experience, and felt that she had been left out of a lot of the decision-making processes there. So I wanted to introduce her first story and talk a little bit about that experience. So if you want to take a moment to just kind of think about, like, what is your first reaction or your reaction to hearing her story? But what I'd like you to do is maybe raise your hand through the reactions or the reactions tab, and let me know what were some of those challenges you heard that Janelle was experiencing. Otherwise, you can throw it in the chat. What were some of those challenges that you heard Janelle talk about? Yeah, thank you, Christine. Definitely judgment. There's a judgment by a couple individuals.
And Elizabeth has her hand raised, Nicole.
Oh. Go ahead, Elizabeth.
Hi, my name is Elizabeth Phelps. I am a house manager and fax ambassador for Samad's House. Fax stands for Fentanyl Accidents Continue to Soar. The only time I was ever able to stay clean and sober was when I was pregnant with my children. But I have heard this story over and over and over again. There's a stigma to that needs to go away. If somebody dropped dirty at the very beginning when she found out she was pregnant, but managed to work an honest program, and pulled this forward, it's lack of care, it's lack of compassion, and they're not looking at the full story. They're just looking at what her previous diagnoses have been. Unfortunately, this is way too common, and it's something that needs to be addressed, or intercommunication or interpersonal communication between the doctors, between the providers, something like that. Because like I said, I've heard this way too often.
Yeah, the excellent points. And it is unfortunate that we hear this, that we're still hearing some of these stories. But yeah, in the chat, I'm seeing things like separation, prejudice, judgment, stigma, exactly. And so Janelle's story is just one of many. However, when I was doing interviews with women, I did hear components of her story in more than one. So this wasn't a one-off, this wasn't an outlier, unfortunately. So in the United States, we know that we're in the middle of this opioid epidemic, with rates of opioid use increasing in the general population, and that doesn't just disappear during pregnancy. So we see that it is increasing in the pregnant population as well. We know that the rate of opioid use in pregnancy is lower than that of the general population, but we do still see that the rate of births complicated by maternal opioid use quadrupled from 1999 until 2014. Opioid use disorder can involve prescribed opioids. It can involve medications for pain postoperatively, opioids that have been diverted, or illegal opioids such as heroin. And opioid use disorder during pregnancy can have negative consequences for both the mother and for the newborn. A complication that we hear a lot about is neonatal abstinence syndrome, or something that we're more frequently referring to now as neonatal opioid withdrawal syndrome. And the difference is really neonatal opioid withdrawal syndrome is it's more specifically defined to withdrawal from opioids. Neonatal abstinence syndrome is more of a general term that could be withdrawal from a host of different substances. So we know that this complication of neonatal abstinence syndrome is a complication that can occur in a newborn. And the reason that it occurs is because during pregnancy, if there is exposure to opioids in the maternal system, that fetus is being exposed as well. And then at the time of birth, there's this sudden stop or this cessation of that passive exposure of the opioids to the infant. And this can lead to some short-term as well as possible lifelong effects for that newborn. Nationally, we have seen that between 2010 and 2017, both the number of women with an opioid-related diagnosis at the time of delivery, as well as the number of babies being born with neonatal abstinence syndrome have increased. And then last April, the state of Wisconsin published their maternal mortality rate data for the years of 2016 to 2017. And in that data, we saw that 48% of pregnancy-associated deaths were related to an overdose. And that equated to 16 mothers that died from overdose here in Wisconsin during those years. So maternal substance use in pregnancy is one of the health issues where this harm reduction approach, or those harm reduction principles, has really been embraced. So organizations like the American College of Obstetrics and Gynecology, the Society of Maternal Fetal Medicine, as well as the American Society of Addiction Medicine, have come together and created guidelines and recognized that focusing on harm reduction principles in pregnancy is going to be our best way of managing opioid use disorder in pregnancy. So with harm reduction, what we're focused on in harm reduction principles is not viewing addiction as a moral failing or a disease that requires abstinence being the only goal, or complete abstinence being the only goal. Harm reduction allows us to use more of a pragmatic and compassionate way to minimize harm and the harmful consequences of the addictive behaviors, and really helps us to focus shift our focus from an absolute reduction of use to a reduction of harm from the use of those substances. And we see that in what's considered the gold standard for our treatment of women that have opioid use disorder during their pregnancy. The recommended treatment for opioid use disorder during pregnancy is a combination of medications along with cognitive and/or behavioral therapy. Most frequently, the medications that are used are methadone or buprenorphine. And I know Terry sent out some handouts that go into detail about those medications. Both are opioids, and what they do is they help to reduce cravings and prevent an individual from going through withdrawal. So we have an opportunity to reach more pregnant individuals with what is considered this gold standard, when there's been some research looking at how many women with opioid use disorder during their pregnancy are receiving this gold standard of treatment. And specifically looking at like Pennsylvania, and when looking at Medicaid individuals, only 56% of the women with this diagnosis were using medications for opioid use disorder. And then a smaller amount of those women were receiving that cognitive or behavioral therapy in conjunction with the medications. So we have an opportunity to improve our outreach and hopefully reach more women during pregnancy. So you might be wondering why it is that complete abstinence would not be the recommended treatment. And so on the right side of your screen, the abstinence only, or that medically supervised withdrawal, you'll see that yes, if there is complete abstinence, that does decrease and eliminate any exposure of opioids to the fetus. However, there is a significantly high rate of relapse that can happen. Depending on what article you're looking at, rates of relapse range anywhere between 56 or 59% to approximately 90% of individuals if they are using abstinence as their method for recovery. So when we are looking at using medications for opioid use like methadone or buprenorphine, this can, in comparison to abstinence, increase the rate of neonatal abstinence syndrome. But we see that it prevents opioid cravings, it prevents withdrawal, and it reduces the rate of opioid overdose. Relapse during pregnancy is high risk during pregnancy because it can expose mothers and the fetus to transmission of things like communicable diseases during potentially high risk sexual or drug behaviors. It can also increase risk of obstetric complication and lead to the actual potential for overdose as well. So because the gold standard for treatment during pregnancy is the use of medications for opioid use, when I was designing my study, I wanted to focus in on the moms that were choosing to use medications for opioid use disorder. So much of the literature that we have on opioid use disorder during pregnancy focuses on a few different things. We see the literature talking about medical management and outcomes, specifically medical management of the mom during pregnancy and medical management of the newborn after delivery. We also see some focus on outcomes. For example, how many individuals or how many newborns develop neonatal abstinence syndrome. What we don't hear in the literature is this understanding of the process by which women using medications for opioid use disorder manage their pregnancy. So the voice of the women themselves is really missing from the literature. So I wanted to take a comprehensive look at the mother and how she is self-managing. So in my recent study, I interviewed 16 mothers who self-identified as being in recovery and using medications for opioid use disorder as their recovery approach. They were recruited through local recovery and treatment clinics, as well as through social media forums between June of 2020 to November of 2021. The mothers were within 12 months of giving birth of their baby and spoke English. So I've presented some of the demographics and characteristics here, but I did have representation of first-time mothers as well as experienced mothers, so individuals that this was their third, maybe fourth baby. They also, on average, at the time when I interviewed them, the average time postpartum was 3.5 months after their birth. Both types of medications, methadone and buprenorphine, were represented in the sample of women I spoke with, and the length of time in which they were using medications for their opioid use disorder, that varied. Some individuals had begun using medications at the time they found out they were pregnant. And I did have a selection of individuals that had been using these medications for over 5 years at the time of their interview. So the type of study that I conducted, the end goal of the study was to look at the interviews, review the data that I was hearing in those interviews, and to develop a theory. And so the results from my research have developed or have resulted in a theory called pregnancy and early parenting in recovery. And this theory is meant to do more than just describe what I heard them say. It's really meant to help explain kind of what it is that they're doing as well. So I'm going to start by talking a little bit about this centerpiece here where it says growing as a healthy dyad. In labor and delivery, when we're referring to a mother-infant pair, we call them a dyad. And so here, mothers discussed navigating these two concurrent identities, one being a mother and one being a person in recovery. And sometimes those two identities were at odds. The mother spoke of the importance of their medications to their recovery and how important their recovery was to them being successful in being the type of mom that they wanted to be. And yet at the same time, they were grappling with this guilt associated with exposing their babies to the different medication or the medications that they were on for their recovery. Each mother discussed the importance of working to have a healthy baby and to grow in a healthy manner themselves as well. And so there was this sense of this continuous growth, and it was expressed by all mothers. And so that's what's represented here by the center of this idea of growing as a healthy dyad. There was not one specific, I'm going to kind of move from the sun a little bit. There wasn't one specific outcome that every single person identified other than this idea of wanting to have continual growth. Let's see here. Okay. So the quote up there talks a little bit about how one woman was describing that being able to be on the medications allowed them to stop thinking about cravings, stop worrying about what their substance use had done and what it had taken away from them in their life, but it allowed them to really focus on becoming a mom and becoming healthy and moving forward. So the data also identified 6 main processes, or these main methods here, and those are the ones that are listed in red. These main processes that pregnant individuals in recovery are actively engaged in during their pregnancy as well as into that postpartum period. And all of these processes were identified by all of the women that I spoke with, but used to varying degrees. So what I want to do now is kind of just talk a little bit about each of these 6 processes quickly that I learned about through the women that I was interviewing. The first process is this process of maintaining vigilance. Maintaining vigilance referred to the internal work that women were doing to continually survey the status of their recovery and also to monitor their baby's development. So when regarding their own recovery process, women discussed monitoring for and actively working to avoid relapse. This was done by reflecting back on maybe themselves while they were actively using, learning to identify triggers that could lead to use, and recognizing themselves signs of potential relapse. This quote that's listed here demonstrates one woman's recognition of some of the common physiologic and psychological triggers and her learning to avoid those states. So this process of learning what to watch for in themselves. When talking about maintaining vigilance when it came to their newborn, mothers described this constant state of watching for signs of withdrawal in their newborn. And this was specific to that early, immediate postpartum period. But once those initial days and then the initial days postpartum passed, this maintaining vigilance moved beyond watching for those initial signs of withdrawal and moved towards looking for signs of developmental milestones. So for example, they were watching for those first developmental milestones like a social smile, when their baby was going to start responding to their name. And when the baby reached those different milestones in the expected time range where we would expect newborns or the babies to develop, it did reinforce to the women that they were doing a good job as a parent. And it also provided some relief to them because they were still holding on to some of that guilt that the medications they used for their recovery were going to have lifelong impact for their child. The second process that I heard all women talk about was this idea of performing self-care. And performing self-care was this process that they felt was important to meet the holistic needs of the mother and so that the mother and the baby could be healthy together. Some of the examples that women gave were eating healthy, getting exercise, surrounding themselves with supportive people, praying, arts and crafts. And women saw self-care as something foundational, not only to their mothering, but to their recovery as well. The next process that women talked about was something that I called putting in the work of recovery. And this was the process that encompassed all of the learning, the complying with, and the managing all of the aspects of an individual's recovery program. Because the women in the interview were all using medications for opioid use disorder, much of putting in the work meant that they were being involved in all of those daily steps that they needed to follow to be compliant with their treatment and recovery clinics procedures. So balancing the time commitment to complete required group therapy meetings, individual counseling, scheduled and unannounced drug testing, and any other required appointments. For mothers taking methadone, this meant additionally daily visits to the clinic to pick up their methadone. And for one mother, she talked about having a 1-hour round trip that she was driving every day during pregnancy, but then even in that postpartum period. So when she went home at 5 days postpartum with her newborn, that next day she was driving 1-hour round trip to get her methadone. Advocating was another process that I heard all women talk about. This served the dual purpose of building a sense of empowerment for the mother, but also this communicated to others like providers, healthcare providers, that they were capable and that they were prepared. Women felt strongly that they wanted to be involved in the decision-making process when it came to their care, the care of their baby. And commonly mentioned topics of advocacy were things around pain management for the mother while she was laboring and in that postpartum period. Also wanting to be included in the plan of care for the newborn, especially if if their newborn did develop signs of withdrawal. So navigating social capital was another process that all women talked about. Social capital refers to the assistance and the support a person has access to. And as individuals create larger networks of support, their social capital grows. And so this navigating social capital was the process of identifying and using different sources of support. So this could be assistance, it could be sources of emotional support, but mothers described a variety of different types of support that they needed. They talked about determining who is best at meeting those different types of support that they needed. And they talked about seeking out the individual that was going to best meet their needs at the correct time. So not all women use the same sources of support in the same way, but all women talked about this like support triage strategy that they had to help them meet the needs for themselves and for their newborn. The last process that came up was acquiring new skills and knowledge. Mothers were really devoted to educating themselves about motherhood, about their medications that they were on for their recovery, about those potential impacts that their medications could have on their newborn. And this was intentional work done because women wanted to be seen as active participants. They wanted to feel prepared for birth. They wanted to be prepared for when they were taking their baby home with them. And they wanted to be seen as capable mothers by others around them. So women spoke of engaging in each of these processes to some degree. And you could see that there was differences in how individuals were utilizing these different processes. So one thing that I thought was very important in the findings that I had is that not only were women very actively engaged in using these different processes to meet the needs of themselves and to self-manage themselves and their recovery, but I also found that there were personal as well as social factors that impacted how well they were able to use these different processes or engage in those. And so 2 personal factors, their personal experience with motherhood and how stable they felt that they were in the recovery, impacted to what extent they were able to engage in some of these processes. And then the social factor of stigma or experiencing stigma or even anticipating stigma impacted the way in which they engaged in these processes as well. So the personal experience with motherhood in individuals that had prior experience as a mother, so this is maybe their second or their third child, those individuals were not nearly as focused on day-to-day tasks of learning how to care for a newborn. They were more focused on learning how this addition to their family was going to change the dynamics within that family. The personal factor of their stability in recovery was another way that really impacted the different processes. So stability in recovery took into account not just how long that they had identified themselves as being in recovery, but also the perception of their likelihood to relapse. So in individuals that felt that they were new in recovery or fresh in their recovery, those individuals in general were using earlier stages or less advanced processes than individuals that identified themselves as being more stable in their recovery. If we look more closely at the process of maintaining vigilance, and we think about how the factor of stability in recovery impacts maintaining vigilance, we're able to see that mothers that were newer in their recovery were still learning about common relapse triggers. They were learning to self-monitor for signs of relapse. In comparison, mothers who felt that they were more stable in their recovery had already built into their day-to-day lives ways in which they could maintain vigilance. Some mothers even sought out jobs working in the area of recovery and felt that working to help others maintain vigilance allowed them to have be more engaged in their own self-monitoring. Another example of how that stability and recovery impacted these processes was if you look at the process of advocating. Individuals that were newer in their recovery oftentimes did not feel capable of advocating for themselves. They wanted to be involved in the conversation, but they didn't really feel comfortable advocating. They often looked to others to get advice or seek mentorship, and oftentimes in the moment were not advocating for themselves. In comparison, individuals that were more stable in their recovery or felt that they were more stable in their recovery were much more willing to advocate for themselves, advocate for their newborns. They were willing to mentor other individuals about things to advocate for. And I even had one mother who talked about how she was advocating for different policy changes at the state and the national level as well. And stigma, the experience of being judged or othered by individuals, was a social modifying factor that impacted the way in which these processes were used. Again, not all women experienced direct stigma or talked about experiencing direct stigma, but they had heard of others that had been stigmatized. And so this fear of experiencing stigma made women feel that they needed to prove themselves, prove their capabilities throughout their pregnancy and postpartum, always wanting others to see them as capable. So the findings from the study also, interestingly, align very closely with self-management and the process of self-management for other chronic illnesses. So this just really reinforced the idea that, again, thinking about opioid use disorder as a chronic condition is very important. So getting back to Janelle, her second birth experience, her subsequent birthing experience was very different. She was still on medications for opioid use disorder when she found out she was pregnant, because in her clinic, they followed moms for a year after they gave birth. And so when she was pregnant again within those 12 months, she was still already connected with that clinic. And so she continued on her medications during pregnancy. She continued with her group therapy sessions. She partnered with the recovery team. She partnered with her OB. And when she went into labor this time, she made sure that she drove the 45 minutes to the hospital where her OB was working. And this hospital had a partnership with her recovery clinic. The pain management plan that she had developed with her OB was followed, and she had good pain control with her epidural, and she had great pain control postpartum as well. Her newborn was allowed to room in with her, meaning that the newborn stayed with her at all times in the room. And when nurses came in to assess the baby to see if there were signs of withdrawal in the newborn, nurses listened to the mom about how well the baby was eating. They listened to Janelle about how well the baby was sleeping. And so she left the hospital 5 days later feeling much happier about this birth experience and feeling that her concerns and wishes had been taken seriously by the staff. So in Janelle's first birth experience, we heard some of those challenges that are frequent for moms that are in recovery. And here it was a little bit different. So what things were you able to hear in Janelle's second birth story that you felt were different than her first? And I'm sorry, the sun is just getting the best of me.
Catching it right there.
Feel free to raise your hand, comment in the chat. What were some of the pieces in her second birth that you felt were different than her first?
Lindsay just says she was met with compassion. I typed in she had a voice.
Yes, decreased stigma. She was respected. There was some advocacy. Yeah, so she was able to utilize some of you could hear more of those processes. You could hear more that care was coordinated, that she was working with knowledgeable providers. There was trust in the providers that she was working with as well. And that piece of being able to stay, and yes, bonding with her baby, that piece of being able to stay connected with her baby at all times, which was really important to her, she had in that second birth experience. So some things to just kind of wrap up really quick here. The way addiction is perceived by society, including family, healthcare team, even the government, can have significant implications for how individuals with opioid use disorder are treated. Certain commonly held perspectives, such as perceiving like opioid use disorder as a moral failing, a personal choice, these can all lead to more punitive responses to recovery and to treatment. Despite evidence that we know that addiction is a chronic condition, it has genetic and neurochemical components. And so when we talk about opioid use disorder, it's important for us to always remember that it is a chronic medical condition. And like other chronic medical conditions, self-management is going to be a goal. Women who have chosen medications for opioid use disorder in their recovery as their recovery modality during that postpartum and pregnancy period are doing work that's both invisible and visible to us as observers. So it's really important for us to recognize all of the work that they're doing, the fact that they are active agents, they're not passive in their recovery, and that they're working to self-manage their recovery. So we have this opportunity to partner with them. And by increasing our awareness of how actively engaged moms are that are using medications for their recovery, it'll be, hopefully we'll be able to reduce some of that stigma around pregnancy or recovery in pregnancy. Beyond being engaged, the findings also showed that someone's previous experience with motherhood, so whether or not this was their first baby, or this was their second or maybe third baby, as well as their perception of their stability of being in recovery, that those two pieces also impacted the way in which women would engage in those different processes. So it'll be helpful as we are having points of contact with moms. If there's healthcare providers that are working with moms, it's important to take those pieces of information and recognize that an individualized approach is needed. And so by strengthening each of those processes, or even one of the processes that women engage in, we have the opportunity to enhance their ability to self-manage their recovery and therefore grow as a healthy die-in or a healthy mother-infant pair. So again, it's important to help reduce stigma through giving voice to women. I'm hoping that some of their stories and that their quotes will help to further reduce stigma, because we do see from the literature that stigma is one of the greatest barriers mothers are facing. They have the stigma of opioid use disorder, and it's compounded by the fact that it's during pregnancy. And so the stigma that they experience can impact their access to healthcare. It can impact their outcomes for both mom and baby. And because it is that greatest barrier that they have, by again sharing their stories, I'm hoping to decrease some of that stigma. I just wanted to leave you with this one quote. I always finish my interviews with asking mothers, is there anything else that you think I should know? And one woman stated that it's important that I know that the reason why any mother who's in a treatment program, it's to better their babies and themselves. It's not to switch from one drug to another, it's to better their lives. So again, my hope is that we can kind of keep these words in mind and then slowly chip away at some of that stigma that surrounds recovery in pregnancy. I do have just a couple little key resources, but I also have my contact information here.
Nicole, thank you. And we will send this slide deck out. Questions for Nicole. I'm going to stop sharing so you can all see each other. Any other questions for Nicole? Poor Nicole needs sunglasses.
Twist, and there we go.
There you are. Agree with Mary Simon. Thank you so much for being here. A lot of what you said we heard in the small group conversation, which was interesting.
Yeah.
Any other questions for Nicole? We're so grateful for you being here. Yep, lots of claps. We are almost at 4:30, and I realized I skipped right over our opportunity for partners to share any announcements. So while I'm bringing up the very last slide, are there any announcements for us to share? Just unmute and go for it. Everybody's tired. We worked them hard today. So my last slide is just a grab your phone. It's just a one quick question to create a little word cloud, and you can do one more than one word if you want. But how are you feeling? What's one word to describe how you are feeling at the end of our partners meeting today? This was a long meeting, but you guys hung in there with us, so it was a lot of information. How are you feeling at the end of this meeting? And just hold your phone up to that QR code and type a word or two. Oh gosh, great words. Empowered, motivated, invested, hopeful, grateful, excited, support, inspired. So while those are going through, I'm just going to leave that on there for a couple of minutes so you can see the word cloud building. Any final questions for me or Larry or Mary? Anything you want to leave us with today? Well, I want to call out my thanks, my great thanks to my friend Rachel. Rachel, thank you for helping me today. Now you can go on vacation, so have a great vacation. And I will stay back a couple of minutes after if anybody needs to chat or would like to chat. So grateful to you all for being here. Nicole, Colleen, it has been a pleasure these last couple of months working with you both. So thank you so much. Looking forward to continuing. Thanks, everybody. Bye, everybody.